We're back. Strength and Knowledge is back. I'm John Allan, and in this episode, Dr. Zach Atwood and I examine the critical role of prehabilitation in the ACL continuum. In this discussion, we established the non-negotiable objective metrics required during prehab to set a surgical benchmark. We break down the clinical significance of early patient education and provide a transparent blueprint of what athletes should expect during their initial post-operative rehabilitation sessions. Without further ado, let's get into it. Dr. Zach Atwood, aka founder of the ACL Institute, aka founder of Primal Recovery, aka Mr. B Uncommon himself. Welcome to the Strength and Knowledge. You obviously do a great job in the field of ACL rehab, but for those who are unfamiliar, would you mind introducing yourself and what you currently do during your day-to-day?
That was quite the introduction. I appreciate that. So as far as my day to day, a little background about myself is I'm from Metro Detroit area, and continued my PT school through there, and then once I finished up there, started working in Detroit, and then eventually after a couple years, decided to open up my own practice just outside of Detroit as well in Livonia, Michigan. Currently, we primarily see, I would say, a lot of I would say over 90% is lower extremity, and then specifically my schedule, I'm seeing predominantly ACLs, meniscus. I'll have some ankles in there as well, but that's kind of the most of my day consists of. And then as far as online stuff goes, just kind of this past year had a little bit of a passion project of the ACL Institute. That's kind of what that became, as far as bringing on just experts in the field and just doing monthly live lectures to really selfishly try to learn, as I'm going through this myself, and then just being able to bring a cool community that people can, hop on and just learn from people all over the globe. That's the big thing that was my main goal, was trying to connect people who may not be able to go to those big conferences, internationally. So that's kind of what led to that.
Perfect. Yeah, I feel like a lot of people say that like the selfish aspect of being the host or getting all these popular leaders in the field onto the either a podcast or monthly meeting. So yeah, I feel like I definitely relate to that with the more I get into more podcasts. So awesome. Well,
Yeah.
thank you for the introduction, and let's hop right into it. So I think kind of where we want to start off is like the prehab. People
hmm
talk a lot about end stage rehab. They skip over either the prehab or the early phase post op. So we're going to start in the prehab phase, kind of talking about education purposes as well as like graft education as well. So go ahead and take it from there.
Yeah, I mean, to your point, I think it's significantly underappreciated, I will say. And oftentimes, depending on your area, you may run into an issue where, whether it's the patients themselves who just, think that they have to rush right into the surgery, are not educated on that aspect, which I think that's where we can do such a powerful job of like just educating the importance of it. And obviously context is key too, because if I got a professional athlete, well, that might be a little bit different compared to, a youth high school kid, as far as how fast do we get them into surgery type of thing. But, as far as the prehab process, like we try to really emphasize, 4 to 6 weeks of prehab if we can, if we have the ability to educate. And I would say we've got a good relationship with a lot of the surgeons in our area, to where they trust our judgment as far as where a person is at. If they're not hitting milestones, if they're still walking with a limp, their knees still swollen, they don't even have full extension, those are problematic things that if we don't take care of that before surgery, I always tell the patient, it's going to be a lot harder to get that after surgery if we're going in like this, and it's, again, context is key. And sometimes when you have those high school athletes where they don't really care, they just want to get back to their senior season, I can respect that. But, for people who maybe we don't have to have like a time crunch per se, I definitely try to really push that. And I had a kid recently actually who, he's a professional skier, and, he had a very, complex knee injury just from the ski accident. And he was doing prehab with me for three to 4 weeks, and On that fourth week, he was scheduled for surgery 2 days later, and I said, "Listen, I'm going to talk to your surgeon. I think we should probably push this back, at least a week or two, because I just wasn't happy with, his motion and his swelling, and he was on board, and sure enough, he went into surgery looking way better, with that delayed week, and now he's crushing it. So I always tell people the better you look going in, the better it's going to be coming out. So.
Yeah, I was hoping you would mention that. I saw that video a few weeks back of that conversation, and I was wondering like what exactly. I know you said like looked better. Like I assume gait looked better, range of motion looked
Mhm.
better. Did you take any other objective measurements, like maybe like Tindec, quad strength, or anything else like that that you also found that was like made a huge difference in that week or two to delay the surgery?
Yeah, for sure. So I will do strength testing before as well, just to get their baseline. And the first time, depending on like when they come and see me the first time, chances are if they just injured it, I'm not going to be strength testing them on that first visit when they're coming in, just 3 days, 4 days after their injury. But as the knee calms down, as we're getting closer to surgery, I will say that's when I will, do a knee extension strength test, a hamstring strength test, a hip AB and hip adduction. We'll do force plates if I feel okay with it. It's like I don't want the counter movement jumps or the drop jumps to flare them up. So it's like, again, depending on the case, I may or may not use that, but I'll use like a squat assessment on the force plates, single leg squat assessment if I can, just to get some sort of idea. But I don't really weigh too much into the jumps for pre-surgery testing, even though I know I probably should. It's just more of a, I just don't want to flare their knee up if that's something that, if they got surgery in a few days, it's like I just don't want that to be, you know, I guess pick and choose your battle, right? And I just don't know if that is super meaningful. Now, if I had, let's say I'm in a college setting and I've already got their baseline jumps for when they were healthy, then that's different. But when they just injured their knee, I just don't know. I just don't know if it could be that helpful in that time point, but the strength for sure.
Right.
And then to your question, as far as like, did it go up or where he was at, I was very comfortable with where he was because we went from, 70% of LSI all the way up to 85, which I felt much more comfortable with as far as going into surgery.
Perfect. Yeah, like a lot of the research supports obviously no swelling going into surgery. That's the goal.
Hmm.
There's not a lot of research supporting that there's 90% limb symmetry on counter movement jumps, right? So I
Hmm.
think to your point, it's like it's super important to not flare up that knee. Those numbers are good, but we'll get there eventually. And like really maximizing that like LSI quad strength isolated range of motion and then minimize swelling. So that definitely makes sense with your thought process. And thanks for explaining that.
Yeah, and I think to add to that too, I feel like the reason why I would say also going piggybacking off the meaningful aspect of it is like I already know like if you just tore your ACL, you're gonna adopt a different movement strategy, and is that your baseline? Probably not, and so that's where it's like I just don't know, again how much I can put into that jump really, pre-surgery. So.
Right. Let's dive into like the actual sessions. How different is those prehab sessions compared to like 1 to 2 weeks post-op?
Mhm. To be honest with you, they're very similar. Mainly because our goals are the same. I would say for prehab for those first few weeks post-op, we're our main focus is our swelling, our range of motion, especially extension, getting bending as well, restoring gait. Like literally, I will say it's those first prehab is very similar until they get to, a point where maybe the knee's much more calm, their gait's normal. I will do a lot of BFR as well in the prehab phase as well as post-op phase. And so that's one thing I will say is pretty much lines up very similar. And I think that it helps too just from patients getting exposure to those things before, because I mean, as you know, BFR is not a comfortable thing. And if I can expose an individual to that prior to surgery, it's like they they already know what to kind of expect, I would say, post-surgery. Same thing with NMES. I am using NMES like crazy, even in the prehab phase. And by the time post-op comes around, they're definitely more comfortable with that sensation. Whereas sometimes, you throw somebody who's never done NMES before, they just had a knee surgery, and then now you're trying to throw pads on them and crank it up to as much as they can tolerate. That may be an uncomfortable thing, and you might not be able to get, anywhere with it. So I'd rather expose that to them, before they go under the knife.
Right. Absolutely. And one more question about prehab, then we'll get into more post-op.
Mhm.
What is the difference prehab wise when you get multiple ligaments involved? Like, does your prehab change if it's like bicruciate, if there's
Mhm.
meniscus involved, and even like a knee dislocation? So can you just like kind of talk about the difference between those two, if there is any at all?
Yeah, I would say the big difference for me would be the weight bearing aspect. Like for example, this ski injury, he had a very gnarly bone bruise. Multi involvement. Both medial lateral meniscus, MCL. So we definitely had to take things slower, which is why I really pushed it back. Just because I didn't want to force his motion. I just like I think like sometimes with those, meniscus and bone bruise, I think bone bruises in particular, you really have to be mindful of how much weight bearing loading you're doing because that can they're all over the place. It's like it could be a small bone bruise, a large bone bruise, and you kind of have to really pay attention to your sweep test and see how the joint's responding to what you're doing. So I would say like I probably will bias more open chain work for the individuals with a lot of the multi-ligament meniscus chondral involvement. I would say that's probably the biggest difference compared to, just a traditional, but in that same for, the early post-op phase, we're gonna be very mindful of how much we are loading into weight bearing and stuff like that. But yeah, they're tricky. I will say it's every single one is so variable. But for this kid in particular, his flexion and also with the MCL, the flexion was he was getting a lot of pain with just right at the distal attachment. And so again, instead of like really forcing it, I just wanted to really focus on, frequency over intensity. That's kind of what I will tell people. And for him, it just needed a little bit, longer to get that flexion back, but he eventually did. And then, obviously going in, he was feeling much better. So
Perfect.
yeah.
That transitions nicely into my next point about like post-op. We talk about the benefits, like you said, early and often, as well as like keeping the intensity lower. So I just wonder
Mhm.
if like you had any like home exercise program dosage tips and tricks, as well as just like for scheduling PT appointments to come see you in person.
Yeah, so I usually will try to get somebody within the first 2 days post-op, I will say, if I can. That most people in my situation, just with us referring to surgeons in most cases, they usually will already be in good communication with them. So I would say we don't have an issue usually getting them within the first few days, I'll say. So I definitely preach that big time, just to get things moving because sometimes some people might be a little hesitant to, bend their knee or, do anything. Now, if we had them prehab, we've already educated them at this point. So hopefully it's not like a huge scare or like, oh, I can't move my knee or anything like that. We've definitely already hammered that, I would say. And then I would say the big things, I usually try to keep it very, very simple. This is something that in the past year I've really had to dial it back just because my main demographic is your 14 to 18-year-old. I would say that's like over 90% of who we see, and I love treating that population, but it also comes with understanding that they're probably not going to be the most consistent if you just throw a long list of things at them. So I would rather them focus on, I say just, four things I really want you to hammer home. And it's really just categories, your swelling, your extension, your flexion, your quad activation. And that's kind of like the big four that I'll have them do. And then we just find, whether it was during the prehab time or even that early, couple visits of finding whatever exercise will fit that category for them that they feel is the most comfortable or they get the most out of. We obviously have our recommendations for certain things, but like, some people might not tolerate a heel slide, and maybe we have to, figure out how can we get this person to bend their knee, comfortably. So that's what I would say the big four as far as categories go, and really emphasizing, to be honest, the swelling and the extension. And I'll even joke with patients all the time. I'm like, if all you did was lay on your back and put your legs up on the wall for the first week, you would actually probably be better than most people just from doing that, you know? And they're like, "Wait, really?" I'm like, "Yes, that's how important getting swelling out of your knee is going to be because A, it shuts your quad down. B, it's painful when there's pressure in your knee. And C, it's disrupting your motion. So if you literally just kick your legs up on the wall, you're essentially attacking all three of those things with one thing. And so that's the one I really prioritize is that, and minimum I'll tell people an hour a day. You can break it up however you want, but that's like the minimum dose. And if they can do more, even better. And then with extension, I love my heel pops, the strap assisted heel pops, the, low load, long duration type of work as well. We're pretty aggressive in the sense of like we just throw a ton of reps at people. So I'll tell them, 1,000 reps minimum a day. And it sounds crazy when we say that, but again, I'm just hoping that they do 400, and not like giving them two sets of 10 and then they do 20. So like it's one of those things. If again, what is our goal of this? If we're trying to get the motion back, if we're trying to get activation, you got to just do tons and tons of reps, and the intensity is low. So I'm not worried about the amount of volume. And just knowing that it's a 15-year-old kid, I'd be lucky for them to get, 100 reps, and that's a win. So I think that's important when you're working with that age group is overdose it, just knowing that they're probably not going to be hitting that target, and that's okay. So that's where I would say the big four that I tend to focus on, especially in that early phase of like, first 14 days, just keeping it super simple and not overwhelming them with a long, long list of, exercises. And again, it comes down to what your patient population is. If you're working with a player in the NFL, that's obviously going to be a little bit different. But when you're working with high school kids, I would say there's nothing wrong with keeping things, simple.
Yeah, the analogy I keep thinking of is like big doors swing on small hinges, and you clearly have outlined those small hinges with the extension, the swelling, all that good stuff. But and people just don't understand that we can't get to plyometrics, we can't get to strength training, we can't get to return to sport if we don't have those small hinges, just that
hmm
we've set our foundation on. So thank you for highlighting those. I think you did a great job of kind of like making it very cut and dry of. Yeah, we're going to overemphasize, overdose these exercises because they're very important. Not only do you overemphasize them because of the importance, but also overemphasizing them with the thought process of they're not going to hit this, but if they hit 50% of this, they're still getting
hmm
more benefit than doing nothing or doing the 2 by 10 like you mentioned. So,
Yeah, yeah.
yep, let's transition one more point here. Talking about like we talked about BFR and NMES post or prehab. Let's talk about
Mhm.
how early we're getting it post-op. I know you say keep it simple in the
Mhm.
first 2 weeks. Are we still implementing that if we did it in prehab? How different does that change if we haven't had the prehab aspect?
Yeah, so I guess that's actually a part I missed of your question earlier as far as like our frequency of in-person sessions. But usually we've developed like a new plan to where we'll usually see people anywhere from 3 to 5 times a week, just based off of this new program that we've built out for our AC or any post-op, I would say that's kind of what we've shifted towards. But yeah, as far as BFR and NMES. I will implement that within the first week. I'm doing NMES day one if I can when they're in clinic, especially if they've been exposed to it, prior. I will still use it for individuals who are, maybe coming to us who haven't done prehab with us. The only difference that I will say that may change is just how aggressive I am with getting them to feel the high intensity that I'm trying to look for. But in that phase, like the first week, to be honest with you, I may get an individual to, if they're bending right to 90 degrees and we're not having any issues there, then I'll feel okay with, setting them up on NMES and starting with some isometrics there. But if they're struggling in that first, 7 days, or if it's more complex, knee injury to where bending might take more than just that first week to get them to 90, then I might, delay it from a sitting isometric standpoint, but I'll still use it with their leg raises and stuff like that. And then same thing with BFR. I feel, comfortable within those, around like, 7 to 10 days, starting to initiate doing that. And the only thing that I would say that I probably will adjust is just the pressure at the beginning, just to get them a little bit more comfortable with it. So I might start with like a 60% limb occlusion pressure, just get them familiar with it, because chances are they're probably not going to be taking things to complete failure in that first week, but just kind of getting them reintroduced to it. And then from there, I'll just progressively increase the pressure over those next couple of weeks. But I definitely like to use it within the first 2 weeks for sure. And then yeah, NMES is a big one. We'll use tens as well. So that's actually something I probably forgot to mention, was every single patient that is coming in for an ACL or any knee injury or surgery, I should say, they are going to be icing their knee on the way into our clinic. And the nice thing is, within those first 2 weeks, chances are they're not driving, so they can definitely wrap their knee in ice. Most people are driving about 15 to 30 minutes to see us, which is perfect. But they will be prescribed a home unit. So we will give them a TENS unit slash NMES unit that they can buy, which they will be prescribed to do multiple times a day. And then they'll use that TENS while they're wrapping their knee, just right around the knee, on the way in, so that we're getting the focal joint cooling as well as the TENS to try to give us a nice window of quad excitement activation. And we've been seeing some really positive results from that. And that's really, I've got to give the credit to Dave Sherman for really opening my eyes for that one, because that's been a complete game changer for us as far as that early post-op phase.
Yeah, I've used it. I was at treating ACL, and we were at a sticking point regarding like quad activation. A little bit later, ended up having a manip, and we reintroduced that prefocal cooling. I think it was around like the 2 month mark, 3 month mark, and like we were seeing those numbers that they were talking about, like doubling, tripling,
Hmm.
quadrupling the amount of quad activation and torque and Newton's force in the quad. So that was definitely eye-opening when I first heard that story, and it was really cool to see in person the
Yeah,
actual
yeah.
effects of prefocal cooling on AMI and all that stuff. So I'm glad you mentioned it, and definitely we could probably have a whole nother podcast on that concept, but I think
Yeah.
we're probably gonna call it there on that conversation. Do you have anything else that you want the audience to know about this phase, the early phase, how important it is for either the athlete or clinician or anyone just watching?
I mean, I guess I'll just mention what I usually tell to my patients or anybody is like, this is the most important phase in my opinion. I think it's super underappreciated, super undervalued. Often just like, let's get them off the table as fast as we can, get squatting and all this type of stuff. And it really, if I always say you can't win rehab within the first month, but you certainly can lose it or at least prolong it. And that's where you really have to take this phase super, serious and do the work and hit the basics. Like I can't emphasize that enough. If your knee is swollen, if you don't have extension, those are signs that you should probably not be pushing forward. So definitely don't skip those steps, because if you really nail this phase, and I've seen it on a lot of occasions when people really take it serious, my gosh, their recovery is just so smooth, and it really lays the foundation down.
Awesome, Zach. Thank you very much for your time, and I'm sure we'll reconnect and have you on for maybe the later stages of rehab. But I appreciate your time, and thank you very much.
Awesome. Thanks, John, for having me. Really appreciate it.